Hi, everybody. Welcome. And thank you for joining us for our webinar, Quick Insights with Quarles, DEA Proposed Rule for Controlled Substance Prescribing in Telehealth. What happens next? That is a mouthful. Okay, so I'm Katie Revega. I'm a partner here in our Indianapolis office, formerly of Phoenix, with experience as an in-house attorney and chief compliance officer for a healthcare app and national pharmacy company. I advise technology companies, investors, and healthcare providers on regulatory compliance and transactions involving telehealth or pharmaceuticals. Today, I am joined by my colleague, Chris Dang, who is a partner in Phoenix. Chris counsels medical practices and pharmacies on regulatory compliance, particularly with respect to controlled substances. We've been working together for more than 10 years at this point, and we're really excited to be doing this program for you. Before we dive in, a few logistics. All of our comments in today's webinar are off the record, not for publication. All attendees are in listen-only mode. We welcome your questions. Please put them in the chat box under the Q where it says Q&A, located below the slides in the webinar dashboard. If we don't have time to answer questions during the webinar, we'll follow up over email. And you know us, or if you haven't met us before, introduce yourself. Please reach out, email or phone. We'd be happy to help you out and answer your questions. You can also turn on closed captioning during the live webinar by clicking on the CC icon in the lower right-hand corner of the video player. This webinar is being recorded. All registrants will receive the on-demand link within a few days. You can share it if you know of other people who might be interested in the program. That's just fine. And with that, we're going to get started. I'll show you first the agenda. We're going to talk a little bit about the buprenorphine, that sounds a mouthful, final rule and the Veteran Affairs final rule before we dive into the special registration. Just give you a quick overview of both of those. And with that, I'm going to hand it off to Chris to start us off with buprenorphine.
Thanks, Katie. So first off, we have a telemedicine final rule for the prescribing of opioid use disorder treatments. Right now, that's buprenorphine. That's authorized under the rule. So practitioners beginning February 18th can be prescribed buprenorphine for maintenance treatment and detox treatment via interactive telecommunications and telemedicine systems, including audio only, so long as the practitioner is authorized by the DEA registration to, in this case, prescribe that Schedule III controlled substance in buprenorphine, and the prescription itself complies with all the other facets of law, right, including the medical necessity of the prescription. That can be for a 6-month supply, up to a 6-month supply. But before you can prescribe, you must review at least 1 year's worth of PDMP data. If 1 year's worth of PDMP data is not available, you can review what is available. But if the PDMP is offline and not available, or there is none, you are limited to a 7-day supply. So that's a key aspect for the prescriber to be aware of. You can continue prescribing after that 6 months initial supply if you conduct an in-person medical evaluation or you conduct another form of telemedicine encounter. So you can't use audio only to continue bridging and prescribing successive prescriptions. So that's another key kind of compliance point you have to be aware of. Lastly, on the dispensing side, there's work to do for pharmacies. Pharmacies must verify the identity of a patient, either a state or federal issued photographic ID card or other form of identification. The other form of identification is key, right? We're dealing with a lot of individuals and folks that may be in between homes, unhomed, in shelters, or other kind of living situations. So the rule does allow for alternative forms of IDs like bank statements, voter registrations, letters, and the like, to kind of allow people that access so long as they just bring something to help them verify who they are or says who they are. It does not need to have an address. Again, photographic ID, all forms of government identification, great, but there's also allowance to, care for and tend to the individuals that seek these medications or need these medications in the most vulnerable states.
Do you think that adding that as part of this was a DEA response to comments, or was that part of their original proposal?
Oh, most definitely. If you looked at the original proposal, right, we had a much more constrained initial day supply, 30-day supplies, after which you had to, in line with the original telemedicine rule as well, go to an in-person medical examination or be at a facility with a telemedicine system with another practitioner conducting that or referring that out to a qualified telemedicine referral. It was fairly onerous, it was fairly constricting, and somewhat, many commentators argued, not as forthcoming in providing the medications needed that the Act and policy and industry and communities have been saying, hey, we need to get these prescriptions out to folks. We need to reduce these barriers. We still have safeguards in place. But again, they wanted to, again, open that up a little bit more. So we saw, I think, in this case, in this instance, not in all instances that we're really talking about today, DEA really listening to input and kind of drawing back. So that's what we have in the final rule, much wider breadth, much more allowance to provide these products.
Well, that's great.
All right. Next, quickly, another final rule, the final rule for telemedicine for Veterans Affairs patients. So VA practitioners can prescribe controlled substances by telemedicine if they are employed or a contractor with VA. The VA patient has received, and this is important, right? At any time, an in-person medical evaluation by a VA practitioner who at the time had the ability to prescribe or in their scope of practice or position have the ability to evaluate and prescribe drugs. That's just the one gating kind of exam requirement that they are imposing. But again, that's very broad in your care with the VA. That there are certain limitations on settings where prescribers can do this, so that's going to be important to note as well. Cannot be a contracted provider working outside of a facility or in other certain settings. You, of course, still have to have a legitimate medical need for that prescription, and you must review the VA's electronic health system and state prescription drug monitoring program. If the system is not available or there's other technological issues, you get constrained down to a 7-day supply. So an important note there. Again, in the kind of mission statement and the kind of closed environment of the VA, the mission and the commentary kind of led to, hey, let's have a rule that allows the flexibilities that we saw during the pandemic really translate down into the set of professionals caring for our veterans. And in this case, right, they targeted and issued a final rule here, very pinpoint to VA patients and providing continuing accessibility. With that, I think we wanted to kind of just provide a kind of that targeted kind of discussion on the things that are final, and what we have all been waiting for, I'm sure, though, is the more weighting that we will have on the regular general telemedicine rule. And to kick that off, I'll turn it back over to Katie.
Okay. All right, so here's the slide on that one. The proposed rule, thank you so much, Chris. The proposed rule is, if you haven't looked at it yet, it establishes a framework, or would establish if it was effective, a framework allowing some kinds of healthcare providers to prescribe controlled substances without a prior in-person visit. Now, at times there have been concerns from a telemedicine perspective that the in-person visit requirement would be continued indefinitely, and the DEA would maybe never get around to proposing special registrations, but here we are, long awaited, and has it workable, not workable? We've got some thoughts on that for you. Some organizations, just so you know, have already requested DEA to rescind this proposal. They're accepting comments until March 18th, and some of the initial comments have been, please don't do this. There's no indication yet how the new administration is going to handle it, but this is not part of the regulatory freeze on new rules that they had imposed because of the timing and the time for the comments. When DEA rescinded the previous proposed rule last year, they had received over 30,000 comments to that rule. And as Chris was explaining, related to the buprenorphine rule in particular, they are trying, especially in the telemedicine space, to be responsive. And they do listen to the things the providers say, physicians, platforms, pharmacies, the whole spectrum. Now, whether you're preparing to submit comments or just considering how this might affect your business, we do appreciate that it's good to have an idea of what it contains. We may not talk about in detail about each of the topics on the slide. This is to show you the general things that it covers. Normally when you go and there's CLE stuff, then you have all the detail and the citations and things, but we really wanted to just be able to hit some highlights and talk through some of the implications of some of them. And then again, if you have specific questions or help preparing comments to submit, let us know. We're happy to do that. in terms of really getting into details, Chris is going to kick it off with some explanations around the provider registration, the special registration rule for the providers themselves. Then I'm going to talk about the platform piece. We're going to cover some of the other aspects if there's time. So Chris, go ahead and kick us off with the registrations for telemedicine providers.
Thanks, Katie. And I love your comment about we're finally here, right? That's 16 years after the Ryan Haight Act was passed.
Yeah.
We are finally here. I guess we're going on maybe 17 this year, right, in 2025. So that's just the time scale, right, that we're dealing with. Sometimes that DEA works with decades to get rules passed and finalized. But I think, as we all know here, right, the pandemic really kick-started the transition over and adoption of telehealth and telemedicine. And now that genie is out of that bottle, the DEA has had a hard time putting that cork back on, right? And industry and you all here on this session here have really kind of spoken up for that, right? And so at least we are seeing traction, we're seeing movement, and perhaps a little bit faster. Knock on wood, I'll be a little bit optimistic that we get more successive back-to-back edits here to get to a final faster than we have before. Certainly hope for another 17-year kind of delay. So with that, right, what is DEA has to box? DEA is in somewhat of a box, right, with the Ryan Haight Act. There's kind of three kind of core principles that they have to put into and bake into the agreement, short of an amendment to the Ryan Haight Act or a replacement thereof. And first, DEA has to have a structure that requires a need, right? They can't issue the special telemedicine registration, or special registration is what they're calling it, willy-nilly. They can't just offer that to anybody who applies for it. So by the purposes of the Act, they have to have some sort of statement of need, showing of need. Next, they have to make sure that not just they hold a registration, but they have to require practitioners to be registered in the specific state. So we'll talk a little bit about that today and how that's baked into the proposed rule. And lastly, there still must be, right, overriding, a bona fide patient-prescriber relationship built into every prescription. Right? That's never gonna go away. It's fundamental to the core of prescribing a controlled substance prescription. So element and key to that, there are now 3 proposed general classification categories of registration. The telemedicine prescribing registration, which would authorize practitioners to prescribe Schedule 3 through 5 controlled substances. An advanced telemedicine prescriber registration, which would allow them to prescribe C3 through 5s and 2s. And then a platform registration, which is an entirely new concept that Katie will talk a lot about in a little bit. So what are the requirements of getting a registration, right? So the base telemedicine prescribing registration, right, for C3 through 5s, you still have to show a need. You have to show a need for the registration because without it, there will be significant burdens on obtaining and connecting into a bona fide relationship with that patient. That is, for example, geography. The patient lives in a rural area. There's weather conditions or other conditions that prevent people from coming into the clinic. So parts of the country where it's quite mountainous and passes may be snowed into the year, which still happens, right? That could be a use case and scenario for that. People with communicable diseases and disease states, which make in-person visits difficult. Anything that kind of prevents you from seeing people in person in a legitimate basis, you're gonna have to show that in order to get that registration. Now we believe this is probably going to be one of the main points, that folks are going to comment on through the comment period. What is going to be that kind of evaluation? Are there going to be more examples? What is the tolerance here? How will that play out? Again, still early on in the terms of discussion, but get your comments in if you've got comments on that particular rule. Now, the advanced telemedicine prescriber registration. Take those elements and then add on to that. Hey, what is the specific need then that you have to issue Schedule 2 controlled substances in this environment, right? You have the DEA expects that this registration, and this is the present language, is reserved only for the most compelling use cases. ensuring that Schedule 2 prescribing via telemedicine is only used when necessary. So it's going to be an even heightened level for Schedule 2 controlled substance prescriptions. And on top of that, they've limited it to certain board-certified professionals and specialized professions, prescribers, in the following areas: psychiatrists, hospital care physicians, palliative care physicians, physicians rendering treatment in long-term care facilities, pediatricians, neurologists, and certain board-level certified individuals in those related areas. So again, heightened requirement to show why you need to C2s, and then a much more narrow band of practitioners and specialties authorized to obtain that registration. There's also that state component that I mentioned earlier, that there's an expectation for prescribers to be registered with the states. They're creating a new registration category in the ancillary kind of environment called the state telemedicine registration. Now, despite its name, it's not issued by the states. It's going to be issued by DEA, but that tag, that registration, is going to be specific to each state where the prescribers are going to be practicing and they're seeing patients. So another layer on top of that. So now, Katie, I'll turn it over to you for the entire new concept here in this layer cake of registrations on the platform registrations.
Sure. Thank you for that. It's interesting. They've taken something that could be maybe relatively straightforward and made it very complex and multi-layered. Platform registration, however, does not have that bifurcation between Schedule 2 and the rest of the schedules. A platform, technology platform, does still have to show need for the registration, such as intending to facilitate telehealth encounters for patients who might be prescribed controlled substances. You could list that as a need if that's one of the business purposes of the technology. But you don't have a separate registration level or different requirements if you're handling C2 prescriptions versus C4 or something like that. It's the same, but you still have to have it. In terms of the proposed rule itself, it's interesting in how it's written because it includes extensive explanations about definitions and justifications for why DEA wants registration for technology companies. They point out that, and they would register them, by the way, as dispensers. They point to the definitions of dispense and practitioner, along with other examples from the Ryan-Haight Act discussing telemedicine intermediaries, which is interesting because those were people. You know, when you do remote and you would have sort of a telemedicine facilitator in the room and that sort of thing. They're sort of thinking of a platform as that, or they're trying to analogize it to that. But I wonder then too if they would eventually scope in e-prescribing software or other types of services, Verizon, Zoom, anything where people are doing an encounter or meeting. You know, people use telehealth with a lot of different kinds of technology, and not necessarily all of it is technology that's dedicated to telehealth. So I think it's going to be interesting to see how that would actually be implemented. But the rule calls for the platform to have a license as a dispenser in a state and a regular DEA registration. And it includes some vague language like unless an exception applies, which might mean that the state doesn't, you know, license telehealth platforms, which they generally don't. State healthcare boards do not license software. They license and regulate people. So some state boards, depending on the scope of their enabling acts, for example, would not even have the authority to do this. So there's a lot of practical considerations to implementation. So this rule feels like maybe it's halfway to something workable, like they have some ideas, but they're not fully baked yet, perhaps. I don't know how it would pan out, for example, and people who work in policy might be especially interested to think that through. If you have state legislatures in every state trying to create a new board for licensing healthcare technology, or are they talking about expanding the enabling acts of their existing board so that is the regulator issuing this, the medical board, pharmacy board, or is DEA going to accept that there is no state counterpart and still issue a DEA federal registration without that state registration, which is normally a precedent requirement for a person. So it's going to be interesting to see how that shakes out since they've done this approach instead of the auditing approach that they've taken with e-prescribing software, for example. Some of the other issues the rule establishes, in addition to saying that you have to have the DEA special telemedicine registration, you also have to have a state telemedicine registration for your platform in every state where the platform is providing services, facilitating interactions between a provider and a person. So the platform itself would also have multiple of those, as Chris called them, the ancillary registrations under that state telemedicine registration that DEA would issue, separate from anything that a state might issue. The rule also, the proposed rule, would establish standards for platforms, including verification of the prescriber credentials if you're allowing a prescriber to use the platform to meet with patients. Most technology already does this in some respect or another, as part of their compliance with other laws, or through their contract arrangements and things like that. But this would make it a DEA requirement as well. And then finally, there are a few exceptions to the platform registration requirement. And that includes, if the rule was finalized as it's currently drafted, assessing whether the technology has to be, a DEA registrant then is going to be kind of fact specific because of the various exceptions. Hospitals, clinics, insurers, and local in-person medical practices, which is a new defined term, and it has a geographic ratio and some other components. Those are all excluded as things that would be required to have the telemedicine registration as a platform. But if you're not one of those, and there's several enumerated features. For example, if the platform entity has financial interests in any kind of pharmacy that will fill controlled substances issued through the platform, then the platform must obtain a DEA registration. So I thought that was interesting because they're moving into things that are also regulated by other people in terms of payments and financial arrangements. And that's not strictly within DEA scope related to following the drugs and the supply of controlled substances. So it's a very interesting, different approach, and it's a little bit broad and calls for some things that, don't seem to exist at this time. I'm not sure if they're trying to regulate the world as they see it, or if they're trying to form the world into something that they want it to be. It seems to be a little bit of both.
Hey, Katie, how did we get from one special registration that was set dormant for almost 16, 17 years to what, 7? How did that happen?
I know. I don't know. It seems like a committee, maybe. Everybody has their thing that they want to address, and it's an opportunity maybe to just add other stuff. I really don't know. And it does seem like they're taking something that could be straightforward, dealing with an industry that's already one of the most heavily regulated in the country, and piling on complexity that may not be necessary to achieve the goals that they're looking for. Because under this proposed scheme, there are also requirements. We have at the bottom of the slide just a reference, additional prescription requirements. All of the relevant DEA registration numbers would be required to be on the prescription. So you have to, of course, they have to be e-prescribed. So if you think about the intersection of those requirements, you could have, and Chris and I met earlier, we were talking this through, you could have up to 7 different DEA numbers on it for one patient encounter between one prescriber and one patient. And those 7, if you're counting, is the prescriber's regular DEA number, their telemedicine DEA number, plus the prescriber's DEA number for the state where the prescriber is, and the DEA number for the state where the patient is. So that's 3 special registration numbers, 1 regular number. And if you're counting, that's only 4. So why did I say 7? Because the prescription also has to include the platform's DEA registration number, plus each state registration number the platform has for if the patient, the prescriber are in 2 different states, or just 1 state if they're in only 1 state. So you can have up to 7. So if you're thinking about your e-prescribing software and the information you get on our prescription, there's going to have to be updates in the software. How are you going to check that? And then the poor pharmacists, this also includes expanded corresponding responsibility for the pharmacist to check all of these and verify they're all valid before you dispense a prescription. So that has impacts for staffing, workflow, software management, the whole gamut. So it seems quite silly to me, given how regulated all those things are already, and there should be a more direct, straightforward way to do this. And you know me, I'm a fan of business-friendly, compliant, practical solutions to things. Sometimes that takes a lot of effort up front, but it pays off later when things scale. And that's why I say I think this rule feels like it's about halfway there. A little more thought, and they might be able to get past some of this duplication, but this is what they've proposed. Chris, we've got a few minutes left, 6 minutes. Is there anything else about the proposed rule that you think or stood out to you as well as surprising or is going to take some serious work to implement?
Yeah, well, thanks, Katie. The one thing that kind of stood out is a national PDMP requirement, right? That
Oh, yeah.
there be a national PDMP system out there, which presently, as many of you know, does not exist, right? We have almost every state and jurisdiction operating their own, many of them on similar platforms with interoperability and connectivity to EHR systems as well and pharmacy systems. So that has been built and designed, and many of you are implementing various aspects of that today in your practice. But a national PDMP check system and the requirement to check the PDMP where the patient's located, in addition to and other states where the PDMP access may be appropriate as well, and where the prescriber is located as well. So fascinating stuff there. Obviously, another Herculean kind of lift that may have to be imposed in addition to the structural changes in electronic prescribing systems that may have to go on as well. So,
Yeah.
yeah.
That's a really good call out. I think, again, this is something that's maybe not completely thought out in terms of how it's going to implement and operate. But they do give, as much as 3 years after the initial effective date, but the way these things go. And then we had a question somebody asked, and this is for you, I believe, Chris. Can you clarify if the prescriber has to be registered in the patient state, if it's different from their own state, or does that depend on if the state has its own registration? So that's the DEA special registration versus the other. Yeah.
Yeah, right now you're going to be, when you're thinking of the nexus of people where they're located, right? If we're in the same state, right, the number of registrations that we have is down. You'll have your basic registration, your special telemedicine registration, and the state registration. I think in the where you're operating. Now, add another state, you have to get that add on to that state registration there at a minimum as well.
Yeah. So in that case, then if the patient's in a different state and that state does not issue a controlled substance registration, because they don't all, you would have your DEA registration plus your DEA telemedicine registration in that state. So the telemedicine registration is additional and on top of all of the existing registrations. It doesn't replace anything or roll anything up.
And there's probably going to be a layer of state reaction as well, right? Some states do issue their own state level controlled substances registration. So how will they react to this, right? Are they going to say, okay, well, is DEA's registration overlaid onto our state, I guess is good enough? Or are they going to want to impose, start imposing more state controlled substance registration? That kind of remains to be seen.
I wonder if eventually it might go the way of the Form 106, which is the form that DEA requires you to use. Is it 106 or just 6? When you have a theft or diversion incident or suspected significant loss, you have to file a report with DEA pretty quickly. Some state boards used to have their own reporting requirement. I mean, many states have their own reporting requirements in that situation, but some states have added now that you could just send them the DEA form when you send it to the DEA. So I wonder from the state telemedicine perspective if they might say, if you have to get a DEA telemedicine registration, send us a copy, or something like that. I don't know. The administrative burden of some of these things seems pretty significant. People try to figure it out. Yeah, there's a lot of duplication. The poor providers, they're not making it easier to be a healthcare provider. That doesn't seem to have been part of the thought yet, other than allowing people to continue to meet using telemedicine, which maybe in its own way is a little bit of a victory. So we shouldn't overlook that. And I think we're about out of time. I'll let you can look at our picture or our faces on the screen, whichever you prefer. That's the end of it. Unless there's anything else, Chris, before we wrap up.
Yeah, so we have some questions that were submitted online. We'll try to respond to those to you directly because we have your name associated with that as well. So hope everybody's doing well. And if there's any questions that you may have on a particular kind of operational compliance issues, or if you want kind of help kind of considering or evaluating comments, just let us know.
Yeah, thank you so much for coming. We hope you found this useful.